Good evening. This is Dr. John Bennett, broadcasting from Bharatnagar, Nepal, in a continuing series of ACNS Neurosurgical Students Chapter. And tonight we have the pleasure of once again having Dr. Abdul Rana from Canada, a well-known Parkinsonism expert that tries to send his message throughout the world on Parkinsonism education. Now, first, let me introduce the panelists before we turn it over to Dr. Rana. Good evening, Diana.
Hi, my name is Diana. I just graduated with a master's in biomedical sciences from Miami, and I'm currently sitting in California at home.
Great. Welcome, Diana. Gaurav?
Yes. Hello, everybody. I'm Gaurav Bhatta from Nepal, and I'm fourth year medical student. I'm studying MBBS in College of Medical Sciences, Nepal, and that's it for now. Thank you.
Great, Gaurav. Welcome. And Simon, the old guard.
Hello, everyone. This is Simon in Japan. Looking forward to the presentation. Thank you very much.
Thank you, Simon. Simon's a medical student there. And Slaven, welcome back.
Hi, everybody. My name is Slaven Gojkovic. I'm a medical student from Zagreb, and I'm really looking forward to hear Dr. Rana again. Thank you.
Welcome, Slaven. Yosef, welcome back.
Hi there. I'm Yusuf. I'm a fourth-year medical student from Dow Medical College, Pakistan, and I wish to pursue a career in neurosurgery. It's good to have you, Dr. Rana, here. Thank you.
Great. Great. Welcome back, Yosef. Okay, Dr. Rana, welcome back, and it's all yours.
Thank you, Dr. Bennett, for inviting me to share this information. So I would start with the very basic. As most of us know, there are two main types of symptoms of Parkinson's disease. The motor symptoms are bradykinesia, tremor, and rigidity. As the disease progresses, patients do get postural instability. There are many non-motor symptoms of Parkinson's disease. Some of the important ones are dementia, depression, speech and swallowing problems, falls, sleep issues. Some of these symptoms are called midline symptoms. I will come back to midline symptoms in the middle of talk to refer this with relevance to deep brain stimulation. The main treatment of Parkinson's disease is medications with physical rehabilitation, occupational therapy, speech therapy, counseling, and some help from other experts may be needed, such as a psychiatrist, urologist, in some cases gastroenterologist, etc. Selection of medication for these patients dependent upon many factors such as age of patients, motor deficit, etc. As a general discussion, younger patients with milder motor deficit, one could try dopamine agonists, monoamine B oxidase inhibitors, and in patients with adult onset, such as around 50 or so, the dopamine agonist and monoamine B inhibitors are used if the deficit is very mild. But if there is a moderate deficit, then levodopa is the most effective medication. Levodopa is the most commonly used medication for Parkinson's disease, and in the first few years, most patients can complete their daily activity. Most patients can complete their daily activities and have a reasonable quality of life with a levodopa of 300 to 800 milligram per day. However, use of levodopa is associated with motor complications. The young patients are very sensitive to levodopa, and motor complications may develop very early on in the course of the disease. However, it takes few years for motor complications to become very obvious. So when the motor complications become obvious or disabling. Then several strategies are used to solve this issue. As the disease progresses, the on periods become shorter and shorter, and the off periods become longer and longer. And this becomes a problem because in off periods, the symptoms of Parkinson's return, and patients may feel slow, they may feel tremulous, they may have drooling, sweating, feel imbalance, dizzy, and so on. In the beginning, we try to solve these problems with help of medications such as addition of COMT inhibitors, monoamine B oxidase inhibitors. If patients have no contraindication to use of dopamine agonists, then in relatively younger patients, dopamine agonists may be added in addition to levodopa. However, as disease progresses, motor fluctuations become more and more of a problem, and they may become refractory. And at this stage, the role of surgery becomes necessary in carefully selected patients. Other indications are refractory tremor, as well as refractory dyskinesias, which are helped with deep brain stimulation, and role of surgical intervention in treatment of Parkinson's disease becomes very valuable in these patients. Most experts perform deep brain stimulation in patients who are 70 or less, and most centers would exclude patients if they are above the age of 70, if they have significant cognitive dysfunction or psychiatric issues, or if patients have terminal illness or a severe systemic disease. However, selection of these patients is individual. A team of movement disorder neurologists and a neurosurgeon who is expert in DBS treatment, psychologist, psychiatrist, etc. will assess the patients together, and they would decide whether a patient is fit for surgery or not. At this point, there are three main targets for deep brain stimulation. STN is a subthalamic nucleus, VIN, which is ventral intermediate nucleus of thalamus, mainly for tremor, and globus pallidus internus, mostly for dyskinesias. Now we'll talk about the process of deep brain stimulation. So there are several steps involved in deep brain stimulation. First of all, in the pre-operative screening, a movement disorder neurologist first assesses the patient, and family members are preferred to be there because family support is very important for these patients. Then an MRI is performed to rule out any other pathology in brain. Is everyone following me?
Yeah, carry on, Dr. Rana.
Yes,
Hello?
we are.
Yes.
Yes,
Okay, I lost the video.
Oh,
So
okay.
after MRI, a neuropsych assessment is very important. A neuropsychiatrist would assess patients' memory problems, as well as any understanding issues, concentration, problem-solving capability, language function, etc., to identify any changes after surgery they can compare. And this process may take up to 6 hours a day and may last for 2 days. As I said, this gives a baseline if there are any changes after the surgery. Then a psychiatric assessment is done. The psychiatric assessment is usually a one-day event, and during the psychiatric assessment, it's usually a single appointment for any major mood disorders. A psychiatrist would meet patient and assess. Then once these things are carried out successfully and patient passes all these steps, then they come to a movement disorder clinic again, and a levodopa challenge test is done. In this test, patients regular levodopa, which they are taking, it stopped for 12 hours. So overnight, patient does not take any levodopa. Then they come in the morning. Then a movement disorder neurologist will assess the patient, and they will do UPDRS subscale part 3. Then patient is given levodopa, which is a little bit higher than the usual dose. Then UPDRS is again completed when the patient turns on. This helps to predict the response of symptoms to surgery, and there is usually a clear improvement in the UPDRS score. And then after this is done, patient goes to see a neurosurgeon. In the pre-operative clinical assessment, before the day of surgery, patient would go for blood tests, EKG, X-ray, physical examination, as well as anesthesia consultation. Patients may be videotaped to compare their condition before and then after the surgery. And then when surgery time comes, patients get a stereotactic frame to keep their head still and locate the area of the brain where the electrodes are placed. The MRI is performed. Patient goes to OR, and under local anesthesia, patients have electrode placement, and the surgeon shaves the front part of the head, makes the bud holes, and the testing electrodes, when they are placed, the various levels of stimulation are tested, and patient may be asked to do various tasks, such as moving their foot or leg to see the response. Then, once the surgeon identifies the best target place, then the permanent electrodes are placed in the area where patient had a best response. Then the bud hole caps are secured, and the electrode position is stabilized. Patient goes to recovery room, and then within few days, the MRI of brain is performed again to see if everything is in place and fine, and there have been no complication. Few days after surgery, the patient comes back for the battery placement, which is called IPG, internal pulse generator. It is placed under the skin below the clavicle. Patients can go home. The stimulator is still off. Patients are taking their regular medications. Then the patient comes for a follow-up for programming. At that point, the various settings are programmed by the movement disorder neurologist, and then the medications may be adjusted. The dose of medications may be lowered. At this point, patients need to be seen multiple times, and it may take a few weeks before the complete adjustment of the dose of medications may be reached. Some of the complications which can occur in deep brain stimulation are cerebral hemorrhage, infection, like any surgery, seizure, headaches, confusion, pain, paralysis, coma, and other side effects might include numbness, tingling, paresthesia, speech problem, dysarthria, dizziness, paresis, dyskinesias, shaking episodes or weight gain, etc. That's end of today's discussion, and I'll take any questions.
Okay, Dr. Rana, we're a little slow because we're all muted, and it takes a little bit.
Sure.
Okay, students, Dr. Rana would like to entertain some questions from the panel, if you'd like to ask some questions. Simon, Diane, Gaurav, do you have any questions of Dr. Rana?
Simon has done sessions in our previous sessions as well.
Yes, sir. I remember.
Right, Simon?
Very nice to see you again.
Are you still in
Hello.
Japan?
I have one question.
Yes, I'm still in Japan.
Oh, good.
Okay, Gaurav, go ahead. Go ahead, Gaurav.
Yeah, Dr. Rana, nice to meet you again.
Yes, nice to meet you.
Yeah, I have one question. You say that patient has to go after some days for battery replacement, right?
Yes.
But is that battery kept under the skin?
Yes, it's under skin, usually on left side of chest, below the clavicle. And once the battery is placed, the wires are connected to the electrodes, and the wires also are under the skin.
And every time the patient has to get some incision over the clavicle?
Pardon me? Once the battery is replaced, at that time, the patient needs to. The life of battery is several years.
Oh, no, I'm going to ask every time the patient goes to the hospital, the patient has to bother about the incision, right?
Pardon me?
No matter how little it is. Every time the patient goes to the hospital, he has to get some incision, right?
No, not every time. Initially, when the IPG is placed, right, at that time, they have to incise, and it goes below the skin. Then the skin stitches are done. And then once the battery life is over, like after 5 or 7 years, and then they have to replacement.
Okay. Thank you, doctor.
Yeah, and incidentally, Gaurav wants to start a chapter of the Parkinsonism organization in Nepal.
Yes.
I understand.
Oh, yes.
Yes, I have spoken.
Yeah.
So
I have discussed that to the person. His name is Natish Sharma. He is the in charge of International Affairs Committee, and before he went back to because of weekend and everything, he may be a little bit late. But I think
he asked for me my resume, CV, and I sent him, and maybe he's working on that, I guess.
Oh, okay. He's already in contact with you. That's good.
we're watching a live interview. Okay, I'd like to introduce another panelist before you go on, Dr. Rana. Khalid, could you please introduce yourself? Can you hear me okay, Khalid? Just unmute. And Vivek, could you please introduce yourself to Dr. Rana? Go ahead, Khalid, unmute yourself, and Vivek, unmute yourself and introduce yourself, please.
Is Dr. Khan? Dr. Khan, can you please introduce yourself? It's a pediatric neurosurgeon from Pakistan. Dr. Khan.
Okay, I guess we'll wait. Go ahead. Okay, any more questions from the panelists? Simon, Diane, or Yosef?
Not yet.
Thank you, Dr. Bennett.
Okay, so that wraps it up, Dr. Rana.
Thank you so much. It was nice meeting all of you again.